First of all, I would like to thank you for the invitation. And with regard to the patient who are referred for catheter ablation, I think we can divide the patient in two groups. One group is a patient with a history of tachycardia-induced cardiomyopathy, or a patient with impaired left ventricle function. They are typically patients with non-paroxysmal form of atrial fibrillation, and for these patients, we have evidence that it's a treatment that could improve survival. So if you improve the ejection fraction by catheter ablation, if you treat AF-induced cardiomyopathy, or even if it's not AF-induced cardiomyopathy, it is cardiomyopathy induced by other diseases such as dilated cardiomyopathy, the outcome is better if the patient is in sinus rhythm than in atrial fibrillation. So for this group of patients, there is evidence that this treatment strategy improves survival. The other patients are patients with paroxysmal patients, to simplify it, without heart failure, without left ventricular dysfunction. And for these patients, we don't have evidence that is associated with improved survival, but improves the quality of life, because they have less palpitation, they have improved quality of life, and not only palpitation, but from psychological aspect, they can feel more safe. The real cornerstones of all catheter ablation procedure is pulmonary vein isolation. It was shown in many trials that it works. It works for paroxysmal patients as well for persistent patients. For paroxysmal patients, it's the only ablation that should be done, and in paroxysmal patients, no additional lesion should be done or are recommended to do. The situation differs in persistent patients because we know that only PVI isolation is the first step in non-paroxysmal patient, and it works, we know. But if it's enough, it's difficult to say, because the AF freedom is less often for persistent patients. There are a lot of strategies what to add to PV isolation, but no strategy was proven to be superior to PV isolation only. So to be honest, we don't know exactly what to do in persistent patients. We know that PV isolation must be done, but even something more is even more beneficial, like lines or AF ablations or something more that we don't know. So PV isolation is the cornerstone in all of them. There are also some genetic aspects of atrial fibrillation. There are some genes associated with higher risk of atrial fibrillation, but it's quite a rare scenario. The most often risk factors are obesity and hypertension and age. And the prevalence and incidence of atrial fibrillation grows up with increasing age, with obesity, and with hypertension. So we can't do anything against the age, but we can do a lot of with obesity and with hypertension. So the proper treatment of hypertension and to avoid to be obese is very good prevention programs to decrease the risk of of development of AF. The main research was related with the obesity, because obesity is really the most important risk factors of atrial fibrillation. And in the past, there was a lot of non-randomized studies showing that if you lose weight, that the chance to maintain rhythm is higher. However, it was tested in non-randomized, motivated patients. And we try to answer the question, if we add lifestyle modification, mean weight loss, a reduction in alcohol intake, and an increase in physical activity to antiarrhythmics, if the efficacy of this combined treatment is as good as the efficacy of catheter ablation. That was the main question of our study. And we designed a non-inferiority study to compare the treatment strategies, and we expected the results will be similar. And we randomized 203 patients, 100 in the catheter ablation group, 103 in the group that was treated by lifestyle modification with antiarrhythmics. And we were surprised by the results, because catheter ablation was definitely superior to the treatment strategy based on lifestyle modification and antiarrhythmics. The reason can be, first, we did not achieve the weight loss that we wanted to achieve. So our goal was to achieve weight loss by 10% of the initial body weight. Is one reason, and the second is maybe if you're obese and you have atrial fibrillation, it's too late for preventive program. Obesity is associated with atrial fibrillation development. And if you are obese and you lose weight, it's perfect. But if you are obese and an overt atrial fibrillation, then it should be treated by catheter ablation. Of course, if you lose weight, it's better for your general health, cardiovascular health. But if the disease is there in the heart, that to treat it only by, we can say, prevention program, it's probably too late at that moment.